morning, everyone present here. Welcome to day 7 of Acharya Rad Connect 2025, a premier online webinar series organized by Department of Medical Imaging Technology, Acharya Institute of Allied Health Sciences, in association with Indian College of Radiological Technology. I, Muriel, lecturer, Department of MIT at Acharya Institutes, will be your host for today. It is a pleasure to welcome you all to today's session for our webinar series. Today, we are honored to have a distinguished guest with us, someone whose contributions to the field of medical physics and imaging are truly commendable. Allow me to introduce Professor S. Paneer Selvam, who serves as an adjunct faculty of medical physics in the Department of Radiology and Imaging Sciences at Sree Ramachandra Institute of Higher Education and Research, Chennai. With an extensive career spanning 38 years, Sir has been a guiding light for many aspiring professionals in the field of medical imaging and physics. Paneer Sir's influence extends far beyond the classroom. He has been vital in shaping the curriculum for prestigious programs like MD, DNB, FRCR, as well as BSc and MSc in Medical Imaging Technology and MSc in Medical Physics, training the next generation of experts who continue to impact the field. Sir is also deeply involved in quality assurance and safety programs for JCIA and NAPH accreditation process, ensuring the highest standards for practice in the medical imaging domain. In addition to his teaching, Sir has delivered over 650 guest lectures and authored 5 publications, sharing his knowledge and contributing to the scientific community. His ability to simplify complex concepts while keeping audiences engaged is a hallmark of his teaching style. Sir is also the registrar for Indian College of Radiological Technology. Sir has been recognized with several prestigious awards, including Professor Karkala Subbarao Lifetime Achievement Award, Dr. V.P. Narayanan Lifetime Achievement Award, Professor C. Redina Sabapati Endowment Oration. A warm welcome to you, sir, and we are extremely fortunate and thankful to have you, sir, in our midst today. We are excited for the enriching session that you will be sharing with us. Please join me in welcoming Professor S. Paneer Selvam. The session is all yours, sir.
Thank you very much. Very good morning to all of you. First, I would like to thank the faculties, the organizers from Acharya Institute of Higher Sciences, Bengaluru, for giving this wonderful opportunity to be a part of this online webinar series. I also would like to welcome the distinguished faculties on online, delegates, and my dear loving students. This program, as she was mentioning, it's collaborated with the ICRT. ICRT means it's an Indian College of Radiology Technologies, which is a academic wing of ISRT. Let me start with my topic. Today, I'm going to talk about the advances in CT detector technology and overview. I would like to bring the greetings from our institute known as Sree Ramachandra Institute of Higher Education and Research from Chennai. The topics which I am planning to talk for another 45 minutes. Little bit history about the CT scan, instrumentation related to conventional technology, that is about detectors only, and also I'm going to highlight, which is going to be the core content of today's presentation, advances in detector technology, and finally, this advancement, how far it is going to be an advantage for the clinical practice, and finally, I'm going to tell the outcome, that is the potential clinical benefits of this detector technology. So this is my plan for today. You know that CT is one of the top 5 medical innovation in the last 4 decades, that nearly 40 to 50 years, according to the most of the medical surveys. It has proved invaluable as a diagnostic tool for many clinical applications. We should not forget these two scientists, even though I thought I should definitely remember them whenever I talk about CT scan. Godfrey Newbold Hounsfield, who is the inventor of the CT scan, and Alan MacLeod Cormack, who is the physics professor who developed the mathematical problems involved in CT scan. He has designed a solution for that mathematical problem. We call it as a reconstruction technique. So that credit goes to Alan M. McCormack. That's the reason in 1979, both of them shared the Nobel Prize in Physiology and Medicine. So we have to remember them definitely. Coming to the CT scan, a word about that. Fundamentally, you know that a CT scanner consists of an X-ray tube and the detector system, which rotates around the patient to get one cross-section. It means that when the X-ray tube rotates, detector also is going to rotate. So CT scanner makes many measurements of attenuation happens in the human body through the plane of finite thickness, maybe 5 mm or 8 mm or 3 mm. Now the system uses this data to reconstruct as a digital image of the cross section. So we call it as CT scan, computer tomography. Graphy means recording, tomo means cross section. Since we make many measurements, we need a computer to assist in reconstructing the data. Hence, it is called as computer tomography. When you see an image, it is basically made up of multiple pixels. Each pixel represents a measurement of the mean attenuation of a particular voxel. Voxel means when the depth is involved, we call it as a voxel, which extends through the thickness of the section. So this is the basic principle. That means that when I keep a cursor here, I am basically measuring the mean attenuation of that particular voxel. So that is the basic principle of CT scan. Coming to the instrumentation aspect of CT, you know that you have an X-ray tube, we have a detector system. Coming to the X-ray tube, it has a very high heat capacity. It looks like a normal X-ray tube, but the heat storage capacity is going to be very high when compared to the radiography X-ray tube. The radiography X-ray tube, the heat storage capacities are expressed in 200 to 800 kilo heat unit. But in case of CT scan, the heat storage capacities are expressed in 2 to 8 mega heat units or million heat units. And also remember, the tube will have a high or fastest heat dissipation rate is also to be noted. So remember that the X-ray tube, what we use in CT scan, has high heat storage capacity and faster heat dissipation rate. These are the two important criteria when compared to the regular conventional X-ray tube. Coming to the detectors. What do you mean by detector? Which detects the data. So the detectors collects the X-rays that is transmitted from the patient and convert them into an electrical signal. The detector job is to convert the X-rays into the electrical signal. We have a system called as DAS system. DAS means data acquisition system, which converts the electrical signal into digital form because the computer can understand only the digital data. So we have an analog to digital converter here, which converts the analog electrical signal into a digital data. And that digital data will be an input for the image reconstruction system. Reconstruction happens, and finally you see an image on the monitor. Today, we are going to focus about the detector. I have given a small introduction about the CT. Now we will go to the core topic. This is the CT detector. Conventionally, the type of detector what we add is scintillation detector, and second type is gas ionization chamber detector. Coming to the scintillation detector, it has a scintillation crystal made up of sodium iodide activated by thallium. Why it is called scintillation? Because when X-ray falls on this, light flashes are produced. We call it as a scintillation. Hence, the crystal is called a scintillation crystal. So when X-ray falls on this crystal, light flashes are produced. This light flashes falls on the device called as photomultiplier tube. This photomultiplier tube is a device which converts the light into a electrical signal. This electrical data is an analog data. We give it to the analog to digital converter, convert them into a digital data, fed into the reconstruction unit. Reconstruction happens, and finally you see a cross-section image. So this is the oldest technology. Later on, we add a better technology called as gas ionization chamber. Here, this is the gas itself act as a detector. Is usually constructed utilizing a chamber. This total thing is a chamber made up of a ceramic material. Can you see a long, thin ionization plate is there? This is made up of a tungsten plate immersed in a or submerged in a xenon gas. This long, thin plate act as an electron collection plate. So this is the positive end. This is the negative end. When the X-ray comes and interact with this, gas ionization occurs, electron hole pair is created, and this positive ion will attracted toward the respective negative electrode here, which produces a current. So the take home or nutshell message is this ionization of ions produces an electrical current, and this current is fed into the analog to digital converter, convert them into a digital data, and that is fed into the reconstruction unit, and finally a cross-section image is formed. So these both scintillation detector and gas ionization chamber are the good old conventional detector technology. But nowadays, current technology is based on solid state or semiconductor devices. Here, we use a photodiode, which is small and compact in size, converts the light scintillation into a measurable electrical current. Here, the quantum efficiency is greater than 98%. For example, here we were using a photomultiplier tube, which occupies a space bulky in size. So now it is replaced by photodiode, so compact in size. What is the advantage of this technology of solid state? Increased spatial resolution. The noise will be less compared to the conventional technology. Because of that, it has a potential for dose reduction. Now, going into the detail about the solid state detectors, there are two types of solid state detectors are available. One is called as energy integrating detector system. Currently, we are using that. What is the newer technology which I am going to teach you, which has not come to India but is in abroad but very expensive but wonderful technology called as photon counting detector technology. Let us see first about the current technology, energy integrating detector system. In energy integrating detector system, the cross section of the detector looks like this. Can you see the mild yellow color boxes? That is the scintillator, which is made up of gadolinium oxysulfide. We call it as GOS. This is the detector. When X-ray comes and strikes this detector, it converts them into visible light. How much light is produced is proportional to X-ray energy. Less X-ray energy, less light will produce. More X-ray energy, more light will be produced. This light which in turn strike the photodiode. Can you see this plate? That is called as photodiode. When light falls on this photodiode, it converts them into electrical signal, which will become a CT signal basically. These signals are measured and integrated over the time. For a particular measured time, all these signals will be integrated. Integrated means what? Cumulative signal we get it. That is the reason whatever the signal we measured in energy integrated detector system are called as energy weighted cumulated signal. It means that all the signals are cumulative, added up, integrated. So that is the principle behind EID system. I request you, all of you, to understand this concept first. Then only you will be able to appreciate the newer technology which I am going to teach you. To make a summary, when an X-ray photon comes and hits the energy integrating detector, that is the photon hits the detector, at the same time, for example, X-ray hits here, everywhere, all the signals are added up, that is integrated to create the signal that are used to generate the cross-sectional CT image. One limitation in this is this process provides no specific information about the energy level of each individual photon, because this is going to add up. Cumulative only you are going to get, but individual data you may not be able to get it. Individual energy data you may not get it. That is the reason it is called as energy cumulated detector or integrated detector we call it. That is the limitation of this detector system. Now I am going to talk about the advancement in the detector system, which we call it as a photon counting detector system. Colloquially, we call it as PCD system. This emerging CT technology of photon counting detectors can measure each individual X-ray photon that passes through the body, which was not possible in EID. EID, you will be able to get the integrated data only. But here it can measure the individual X-ray photon. That is the speciality of PCD. So this is totally opposed to the current technique, which uses the detector to measure the total energy of the X-ray beam. But here we count individual X-ray photon. So more detailed information about the patient can be obtained. When my detector system is able to count individually the X-ray photon, I may get a better detailed information about the patient, which was not possible by the EID technology. Ultimately, this technology is used to create high resolution images at minimal dose. I also get a spectral information in every scan. I'll tell in detail. And also I get improved contrast with lower noise. Improved contrast means the difference between the blackness in the image between the adjacent area are well appreciated when compared to the EID detector system, of course, with lower noise. Now let us understand first the principle, instrumentation and the principle behind the PCD. This photon counting detector, as I said, it is fundamentally a semiconductor. The semiconductor what we use here is cadmium telluride. This is the material cadmium telluride. When X-ray from the patient strike this semiconductor, it converts them into electron and hole pair. Can you see electron? Hole. Hole means it's a positive charge. Electron and hole pair is created. One pair, two pair, like that. Number of pairs produced is proportional to X-ray energy. Less energy, less pair are produced. More energy, more pairs are produced. Now what happened? This is the cathode end. Can you see this one is the anode, this bar. We call it as a pixelated anode. I'm going to apply a high voltage between this cathode and the anode. Because of that electrical field, it causes the drift of charges towards the anode pixel. That is, electron will be attracted towards the anode pixel. When this got attracted and induces a short charge pulses when approaching this anode pad. So it will induce a pulses. Can you see the pulses here? Small pulse, big pulse, like that you get a different pulses based on the energy. Here when I look into detail, can you see this is small, this is big. It means that this is a low energy, this is higher energy. So energy selective counter signal I can discriminate the energy also here, which was not possible in EID technology. Low energy, high energy, like this, I can differentiate it, discriminate it, which was not possible in EID technology. Here, as a summary, when the photon hits the detector, as I said, charge cloud is formed. You see the negative charge, positive charge, correct? Now, these electrons are attracted towards the positive potential here to generate the images, and the energy level of each photon can be quantified because I told you if the energy is 10 keV, assume 10 pair are produced. If the energy are 20 keV, assume 20 pairs are produced. So, the energy level of each photon can be quantified, which in turn produces high quality spectral information. Spectral information means energy information. We can get it. One important challenges is there in this technology. What is that challenge? That is more important. You people should know it. Semiconductor material like silicon has number of advantages, including purity, abundance in nature. Abundance means availability, and broad manufacturing infrastructure. Everything is easier. But historically, the main challenge with the use of silicon is, as a detector material is, it has a relatively low atomic number material. So when you place in a face-on position means horizontal position like this, the thickness is too thin. Some of the X-ray photon may not be absorbed and it will be passing through. So sufficient number of X-ray photon may not be collected and some may be missed. That is the problem with the silicon. So keeping like this in position, what they decided is they made a vertical position like this so that the length of the detector will be more. Even though it is low atomic number material, the high energy photon, since it has to travel a long distance, the X-ray photon will not be missed. So positioning the silicon sensor like this, we call this as edge-on technology, so that the detector is deep, so that it will absorb all the high energy photon and fast enough to count and quantify the energy of hundreds of millions of CT photon in 1 second. This way, the effective depth of the detector is determined not by the thickness of the silicon, but by its length, allowing the detector to have long and absorption length as necessary. So we are not increasing the thickness. Thickness is same only. But keeping a vertical position, the effective depth of the detector is increased. That is the reason it is called as deep silicon. Depth is increased, so we call it as deep silicon. So I have a comparison. When I keep the detector in horizontal fashion, we call it as face-on technology. But here what I have a problem, I may miss some of the X-rays getting absorbed here because energy may be more, but atomic number is less. So it can miss and it can come out. Detector, it will be missed. When I keep an edge on geometry, since the depth is more, I will not miss any high energy X-ray photon also. So what actually we use is the edge on geometry. Now I have completed the instrumentation aspect. Now finally I'll touch on the what you call the advantages of PCD. So this I'll take another 10 minutes to explain you. Very important thing. There are 4 advantages only. One is smaller detector pixel. I'll go in detail. Second is elimination of electronic noise. Very easy to remember. Intrinsic spectral sensitivity. Intrinsic means inherent. That is, detector itself can differentiate the energy level. So we call it as intrinsic spectral sensitivity. Finally, equal contribution of low energy quanta. See beautifully how 4 advantage. Let us see one by one. What is the first advantage? Advantages of PCD. First advantage, what is that? Smaller detector pixel. See, normally, in case of energy integrated detector, the pixel size is going to be this size you assume. And we have a margin here. This is called as septa. This is called as septa. Why we are creating this? Because when X-ray comes and hit here, light is produced. When X-ray comes here, light is produced. This light should not cross to this side. This light should not cross to this side. So we have a septa in between. This area, when X-ray hits, no light will be detected because it's something like a septa. Material is there, it will not detect anything. Dead space like that. But in case of a PCD, when X-ray hits, directly it is converted into electrical signal. No light component at all. So what I can do, instead of a bigger pixel, here I can make a smaller pixel. Chota pixels. So what is the advantage when I make a small pixel? My spatial resolution is going to be increased enormously. That is the advantage of PCD. But you may ask a question, sir, why not in EID also you can make small pixel? Yes, we can make it. But one problem is, when I make like this, you see, lot of dead spaces will form here. Because I have to create a septa, because light should not go from year to year, isn't it? So this septa is must. If I make small, my septa is going to be more dead space will be there, my detector efficiency will be reduced. That is the reason, in case of EID, I cannot go very small pixel like PCD technology. So take home point, in PCD, I can have a smaller detector pixel, which in turn give high spatial resolution. This is the first advantage. What is the second advantage? Elimination of electronic noise. What do you mean by that? Say, can you see this is the time factor? This is the pulses what we get from the detector. I told you, no, when X-ray comes and it pulses, signal will be, CT signal will be produced. That pulses will be, can you see? This is the pulse, this is the pulse. And you also get small chota pixels or pulses also. But all these are all considered as a noise. That we should not take it. All those things are all called as noises. But EID technology, it is a energy integrated. Everything will be accounted. For example, in EID, you get this pulse, this pulse, this pulse, this pulse, this pulse, this pulse. Everything is averaged. So we call it as energy weighted cumulative. But the electronic noise in this EID technology will be more. But in case of a PCD, this low energy component, I can eliminate it. I will keep the baseline. Above this only you accept. Below this, don't accept. I can give an instruction. That is called as elimination of electronic noise, which is possible only in PCD. Because of that, you have a look at this image. Normal CT sinus with EID technology. When I use with the PCD technology, you see the image difference? Because I am removing all the noise. So I get a beautiful clarity of image. My resolution is going to be superior here. Not only that, look at the radiation dose also. Here it is 0.012 millisievert, but here it is only 0.0063. 50% we are reducing the dose. That is the greatest advantage, isn't it? That is the important message. I request all of you who are participating in this webinar should understand that PCT has an enormous advantage, and one of the prime advantages is dose reduction. So, to put in a summary about the second advantage of elimination of electronic noise, I get different pulses, but I can tell the system and I can keep the baseline. Below this, discriminate, discard that. Above that, only take it. Then all this noise will be eliminated. So with EID technology, whatever noise I am getting, I'll eliminate that, so I get a better image quality in PCD technology. Fine. Coming to the third advantage, intrinsic spectral sensitivity. What do you mean by that? Dear students and other practicing faculties and delegates, kindly make a note. I'm going to teach something called as energy bin. What do you mean by energy bin? Binning of data. I have a different energy of spectrum, I am going to get it. Isn't it? I can bin it. What do you mean by that? Before that, I'll give an example. Then I'll go to the subject. You know that in the hospital, we generate the biomedical waste management. How we are going to segregate the biomedical waste? All the general waste, kitchen waste, paper, tissue, water bottle, can, I'll put it in the green color bin. Infected plastic like a syringe, gloves, I'll put it in the red color bin. Infected non-plastic like anatomical, chemical liquid, laboratory waste, all medicine, all those things, I'll put it in the yellow color bin. Antibiotic oil, metal implant, glassware material, I'll put it in the blue color bin. Sharp, needle, glasses, I'll put it in a sharp container. So what I do, at the source level itself, I am segregating the waste. So I am different, what you call bifurcating or segregating the different types of waste, isn't it? Similarly, binning means I am going to segregate the energy levels. Sorry, I am going to segregate the energy level. For example, below 25 kV, I will discard it. 25 to 50, one bin. 50 to 75, another bin. 75 to 90, another bin. Above 90, another bin. Like that, I can collect the X-ray photon based on the energy level. How I collected the biomedical waste? Based on the nature of the waste. Here, based on the energy. For example, 20 to 40, energy bin 1. 40 to 70, energy bin 2. 70 to 100, bin 3. Above 100, bin 4. So, by setting the more than one threshold, the registered photons can be shorted into several energy bins. Maybe from 2 to 8 I can have. Here I have shown 1, 2, 3, 4, 5, but I can have from 2 to 8 on the basis of energy range. On the basis of energy range, I can segregate. Because of this, now I can say 20 to 40, how many X-ray I got it? 40 to 70, how many I got it? 70 to 100, how many I got it? Like that, I can segregate energy level. Also, I can tell in this energy how much I got it. In this energy, how much I got it. In this energy, how much I got it. Like that, I can segregate the whole data. That is the reason we call this as what? Intrinsic spectral sensitivity. That is, spectrally, I can discriminate the data. You understand? So that is the main advantage of the PCD, which is not possible in EID. Last advantage is equal contribution of low energy quanta. What is that equal contribution? In PCD, there is no down weighting of lower energy quanta. All energies are treated equally. Say, for example, in case of old energy integrated detector, can you see this EID, this dotted line, low energy, so much, higher energy, so much more higher energy, so much. The low energy contribution is less. Medium and higher energy, okay, good. So down weighting, weightage of the low energy is done in EID. But can you see the red color? PCD. Even the low energy component are given more weightage, which was not done in EID. In PCD, even the low energies are given weightage, isn't it? Because of that, I get a better contrast ratio. Why I get a better contrast image contrast? Because I give the weightage to the low energy. All of you know that photoelectric effect is directly proportional to atomic number and inversely proportional to energy Q. Remember that. So at low energy, photoelectric effect is going to be predominant and I am going to get a better image contrast. Remember, this is the physics behind that. I'll repeat once again. EID, the low energy weightage is less. Only the medium and higher energy, they give more weightage. But in PCD, right from low energy, medium energy, and higher energy, they give a weightage. Particularly, they give more on low and medium energy. Because photoelectric effect is predominant because of low energy, I get a better image natural tissue contrast is enhanced. And second thing is, because of this, increase the iodine contrast ratio. Because low energy, photoelectric effect is better. When I give iodine, you know that iodine, why we use contrast media? Because K-age effect. We predominantly use the K-age effect and photoelectric effect will be very high because of this low energy component. So I get a better iodine contrast to noise ratio. Because of that, since I get a better iodine contrast ratio, instead of giving 60 ml, I can give 40 ml. So I can reduce the contrast media volume. When I use 60 ml for a particular procedure in EID technology, when I use a PCD, because I get a better iodine contrast ratio, I can reduce the contrast volume. That is a great advantage, isn't it? Because of equal contribution of low energy quanta, this is achieved. So I hope all of you understand the 4 important advantages of the what you call the PCD. I'll give a small summary about that. Smaller detector pixel is the advantage. Electronic noise we are eliminating. Very good intrinsic spectral sensitivity and equal contribution of low energy quanta. Okay. Now, what is the clinical benefit of that? Now we have understood. I have explained all the technical detail. Now, ultimately, any new technology comes. Is it going to be useful for clinical? That is more important, isn't it? So what is the clinical benefits of PCD? Optimum image contrast, as I said, increased iodine contrast to noise ratio, already I mentioned. Because of that, contrast volume can be reduced and I will get high spatial resolution. All these 4 are going to be a very good clinical benefit. Apart from that, 2 more very important thing is I get simultaneous multi-energy acquisition. All the energy level I can individually calculate, quantify. And the greatest advantage or greatest clinical benefit is radiation dose reduction. The potential benefit of PCD is it's helped to provide clinician with more detailed image of the small blood vessels, vascular pathologies, and malignant changes at the earliest stages itself, which is not possible with the current technology of EID. As a result, photon counting CT has the potential to significantly increase the imaging performance for oncology, cardiology, neurology, and many other clinical CT applications. To make a summary of my whole talk of 45 minutes, I am classifying or segregating into 4 important features. The left-hand side is features and benefits of PCD. And for every parameters or benefits, what is the clinical application? First one, I told you PCD has high spatial resolution. What is the clinical application of that? I get a better temporal bone imaging, better MSK imaging, musculoskeletal imaging, lung imaging, cardiac vascular imaging. Simultaneous multi-energy acquisition is possible. Because of that, the material decomposition, I can do it. I can find out the calculus is uric acid or not. Plaque removal, bone removal, virtual, non-contrast imaging, non-calcium imaging, monoenergetic synthesis, all this can be done. What is the advantage of energy binning? Imaging the large patients, low radiation examination, dual contrast imaging, metal implant imaging. And I told you there is no down weighting. All the energies are uniformly photon weighted and improved CNR with iodinated contrast material. What is the advantage? Contrast enhanced CT, particularly abdomen, neurology, cardiac. All these are all going to be the potential clinical application because of these 4 advantages of PCD detector used in CT scan. Isn't it? These are the take-home message. I'll give a good idea about that. High spatial resolution, simultaneous multi-energy acquisition, binding of data can be done, uniform photon weighting, no underweighting of low energy photon. That will give improved contrast to noise ratio. Iodinated contrast material will be reduced so that radiation dose also can be reduced, and iodine contrast material volume can be reduced. I would like to thank images and the theoretical content and whatever I have shown you for the past 45 minutes, courtesy by Siemens and GE Medical System. Thanks to both the vendors for helping me to prepare these slides. Any queries or clarification, I am very happy to answer to all of you. You can put the question in a chat box. Our organizer can interact with me and I can happy to share. And the last but not the least, the message I would like to pass on through all the dear people who are in the webinar, ready to learn. Always your mind should be prepared. Your mind should be accept for any changes happen in the academic area. Your mind should be ready to learn any new things. Then only you can come up in life. I convey my best wishes and blessings to all the dear students who are attending this webinar. And finally, I would like to thank personally the management of Acharya Institute, principal madam or principal sir or whatever whoever is in charge there, and also all the young, dynamic, my dear faculties, so Swapnil or Murel or the, what you call Jiva, everybody, I want to thank them for giving this wonderful opportunity for me to share little bit of knowledge, whatever I have on the newer technology. So that's the end of the advancement in the CT detector technology. I hope all the participants who are in the webinar are benefited by this. But Last but not the least, finally, I request all of you, go back and teach somebody. Whatever you learn now, you teach somebody. Okay? Then only your knowledge also will improve and the knowledge will be spreaded. Whatever knowledge I am having, I should not keep it in my mind. It should be spreaded off. So then only the knowledge will be going throughout the state, country, or whatever may be. So I request all of you to do a teaching job. Let it be a simple one. Do it so that your knowledge personally will be improved. With this, I would like to thank the organizer.
If anyone has any questions and doubts, kindly put it in the chat box.
So I think one of them have asked what will happen when the pulse pile up happens in the detector. See, that is the greatest speciality of this one is the pile up. You will not that what you call we call it as a dead time. So once you get one pulse, the another pulse, the gap we call it as a dead time. That is going to be very very small in case of a PCD. The piling up will not take place. Individually, everything will be transformed actually. So that will be stored as separately, and at the same time, based on the energy level, it will be stored. Is a EID or PCD best for to identify critical diagnosis? Hey, basically, both are good, but what I am trying to say is PCD is much more superior in picking up the lesions. Okay, the high resolution image you get it. So definitely it is going to be superior PCD, but I'm not, I don't know the exact cost, but I was told it is very, very expensive. What are the major challenges in developing the new detector technology? Yeah, definitely this calcium telluride is very expensive one. That is the main factor. Calcium telluride is a very expensive one. We don't have much challenges as such. Cost is the main factor. By using PCD detector, is it helpful to identify the pathologies without using contrast media? No, it's not like that. No. Contrast media, we have to use it, definitely. The purpose of using contrast media is to find out whether the lesion is a vascularity is in nature, how is the vascularity, all those details we want. That without giving contrast, we cannot find it. But the volume of contrast and the iodine to contrast noise ratio, that will be improved. Volume will be reduced, iodine to contrast noise ratio will be reduced. Why it is available only in abroad? I told you, no, very expensive. Maybe in near future it will come. What are the specific critical? That is a broad topic as such. In CT scan, we have many criticals, right from brain to abdomen or chest. So many things are there. Okay. If you want, we can put it. I'll put it in the group actually. I'll try to take a snapshot and put it in the group so that you can understand because it's a big list actually. I'll put it in the group. You can study. Anything related to this topic, if you ask, it will be easier for. Which generation of CT is using this technology? See, this technology, basically, all of you, I request you, whatever the CT scan you are using today, 128 slice or 256 or whatever the slice, the fundamental prototype what we use is third generation CT scan. The fundamental prototype what we use is the third generation X-ray tube, detector, both are rotating in a 360-degree. Now, development has happened, spiral CT, the number of detector rows have been increased. That detector, what we change now, instead of a EID, we have changed to a PCD. That's all. So basically, the CT scan, what we use, the prototype is third generation. Prototype means the base model is third generation. Okay, Mural, I think almost I answered all the questions.
Yes, sir. If there are no further questions, I think we can wind up the session. A huge thank you, sir, for sharing your knowledge with us today. You have covered all the topics of detectors, starting from the history.
Only one question is that I'll answer. What happens if energy bin is not used? Then you will not get the spectral data. That is the specialty of PCD. Energy bin has to be used. If you don't use that, the spectral data, you will not get it. Once you don't get the spectral data, I may not be able to get the advantage of that, isn't it? So definitely we have to use that. Thank you very much. I think Maidu Suji was the person who was asked that.
Thank you, sir, for answering that. Thank you, sir, for sharing your knowledge, for covering up from the basics of the CT up until the advancements, and your knowledge has simplified this topic a lot to our participants. You have explained the entire topic in such a beautiful way. I'm sure everyone has gotten good knowledge from it. And thank you, and we're very grateful for you for taking so much time out of your busy schedule to be with us today. We are grateful for all your knowledge you have shared and the motivation that you have given to all the participants to ignite their passion for learning, and it is truly remarkable. So before we conclude for today, let me brief the participants about the next speaker for tomorrow. We will have with us Dr. S. Paneer Selvam, Assistant Professor in Radiography, Mother Teresa Postgraduate and Research Institute of Health Sciences, Pondicherry. We'll be talking on fusion imaging of principles and applications. Once again, thank you, sir. Thank you, Professor S. Paneer Selvam, for joining us today and for sharing such valuable insights to us. A big thank you to all the participants as well for your questions and your contributions that has made the session more engaging, and we are grateful for the energy and enthusiasm that you have shown us during this session. We look forward to welcoming you all tomorrow again for another enriching session. See you all tomorrow at 11 a.m. Until then, take care, stay safe, and have a wonderful day ahead.